Callie Roper from the London School, so please come up.
Good morning, thanks for inviting me. I'm going to talk about surveillance and how it's affected clinical practice and policy in Africa. And of course, I'm talking about malaria. So this is just a brief overview about malaria. In 2008, globally, malaria is thought to account for an estimated 243 million cases of fever, resulting in 863,000 deaths. The majority of the deaths are occurring in young children in Africa, while they're sort of in the process of acquiring immunity. These statistics sort of represent the tip of a very large iceberg. So many people are immune or semi-immune carrying malaria parasites in Africa. And here's a map showing the estimated prevalence. You can see there's large areas of Africa where children aged 2 to 10, the prevalence of infection is over 40%. There have been two major treatments in Africa historically, both now abandoned as first-line therapy for treatment of malarial disease, and those are chloroquine and sulfadoxine, which is usually abbreviated to SP. The chloroquine was used in the 1930s, and it was a mainstay of malaria treatment for 70 years. And resistance in Africa to chloroquine only really emerged in the 1980s. When chloroquine resistance spread and chloroquine treatment was failing, people were using SP as a second line, and gradually it came to replace chloroquine as the first line therapy. And resistance to SP emerged in the 1990s, so a sort of decade later. If we look at surveillance for drug resistance to chloroquine, this was largely carried out using in vivo efficacy studies. These are usually based in a single locality, often in a single health facility. Patients are recruited and we follow the success or otherwise of their treatment by looking at parasitemia and clinical outcomes. But it can also be followed by in vitro sensitivity. And it's only when these reports were collated and geographically mapped sometime after the event that the sort of underlying population dynamics of chloroquine resistance in Africa began to become apparent. So this is 1978. This is the first reports of chloroquine resistance. So these are maybe just a few cases. It's not reached a high level in these countries, Kenya and Tanzania. And from that East African focus, within 4 to 5 years, first reports of chloroquine resistance came from neighbouring countries. Within 6 to 7, it had spread, 8 years, and finally, within 10 to 11 years, chloroquine resistance had been reported just about everywhere. And when finally, it wasn't known at the time, but when the primary genetic determinant for chloroquine resistance was discovered to be mutations in a gene called PFCRT, it became apparent that there was a single ancestor for this mutant form of PFCRT, which is found commonly. It's common to Southeast Asia and to African parasite populations. And it was found to have been imported into Africa from Asia, possibly via a single event, or perhaps by multiple events. It's very difficult it's impossible to sort of disentangle the sequence of events after the fact, because it's now prevalent throughout Africa. But if it was seeded from this East African focus, it looks like the dispersal of this mutant PFCRT across the African continent took approximately 11 years. And at the time, national policy decisions about treatment were based on surveillance carried out by in vivo efficacy trials. And these measures were made probably at a handful of surveillance clinics. There was a lot of variability between clinics, but they essentially categorized a sort of period of the lead up to action. There's a grace period, an alert period, the action period, and then finally change based on the percentage treatment failure found in these in vivo studies. So nowadays we have a lot more sort of tools at our disposal for carrying out surveillance. And I'd like to talk for the rest of my presentation about an example that I know well, which involves use of molecular surveillance. And I'd like to talk about how that's impacted on practice and policy. And it involves the continuing use of SP. So SP is still used to present day in Africa, but it's used as a prophylactic, so as an intermittent preventive treatment. And it's used in pregnant women, and it's used in infants, and it's used in children. And it's been shown to be very effective. So, for example, in the use of, and it's abbreviated to IPTI, so IPTI with SP, that's given to the infants at the time of their routine vaccinations in the first year of life, has been shown to reduce incidence of clinical malaria in these under ones by 30%. And in 2009, a committee was convened by the WHO to review what the impact of resistance was having on the efficacy of SP-IPTI, and to decide how to take account of resistance in the guidelines for countries who are planning to roll out IPTI with SP. Just to explain the background to the sort of molecular surveillance, sulfadoxin and pyrimethamine target, so there are variant forms. Sulfadoxin targets DHPS and pyrimethamine targets DHFR. And the DHFR and DHPS genes have mutations which conferred varying degrees of resistance to these two components of this drug. So here are the DHFR mutations, which confer pyrimethamine resistance. Mutations occur at all these codons along the top, and we get different combinations of those mutations. And in turn, those confer varying levels of resistance from very low, sort of intermediate, to high-grade resistance, which is the triple mutant at the bottom there. And here's just a slide showing a study carried out in Tanzania by Alan Malisa and colleagues, when we looked at the effect of the change in policy from chloroquine to SP, looking at parasites in cross-sectional surveys over thousands of individuals over a wide geographical area. So we've got a snapshot of the parasite reservoir here. In 2001, there was a change from chloroquine to SP, and you can see the effect that had on increasing the frequency of the triple mutant DHFR, which displaced the sensitive, while the double mutants, which are sort of conferring this intermediate level resistance, are not actually responding to the change in drug selection pressure. So that highly resistant triple mutant DHFR, which is sort of conferring the bulk of resistance, is now found throughout Africa. And previously, a study which Tim and I and colleagues published showed that it had also been imported into Africa from Southeast Asia. And what we've shown also is that the double mutants, which I showed were conferring intermediate levels of resistance, they're actually sort of homegrown mutants. They don't go on to mutate and become this triple mutant. At DHPS, this is mutations conferring resistance to sulfadoxin. There are two common haplotypes, a double mutant and a single mutant. And the more resistant of these is the double mutant. Oh, sorry, and also mutations at this 436 codon, but we don't think that they have a great deal of effect on the drug tolerance phenotype. When we look at the distribution of these, you can see that the double mutant, the highly resistant double mutant, is largely found in East Africa, shown here in red, while the single mutant, it's either an AGK or an SGK, is found throughout West Africa. So there's an abundance of partially resistant alleles, partially resistant genotypes, a whole range of these genotypes conferring different degrees of tolerance, but in fact, in terms of what's predictive of what happens in a patient, there are really only two genotypes that are important, and they are the West African combination of the single DHPS with the triple DHFR, and the East African double mutant DHPS with the triple mutant DHFR, shown with those red circles. And in fact, the existence of these intermediate genotypes, intermediate phenotype, has sort of confused the relationship between the presence of molecular markers of resistance and the clinical outcome for some time. In fact, it's the quintuple mutant, that is the East African form with the double mutant DHPS and triple mutant DHFR, which is really sort of seriously hampering efficacy of IPTI with SP. And in this case, the existence of the 540 mutations, which are the ones present in East Africa but not in West Africa, are indicative of this highly resistant genotype. And evidence that this committee was presented showing that there was a loss of protective efficacy of IPTI in sites where the prevalence of this mutation exceeded 50%. So the policy recommendation by the WHO was that SP-IPTI should not be implemented where DHPS, the prevalence of DHPS exceeds 50%. So this is work which I've done with Imrani Naidu, who's a PhD student at the London School of Hygiene and Tropical Medicine. We did a literature search. We pulled out all the publications on DHFR and DHPS in Africa. And we excluded studies where malaria had been imported from Africa to non-African countries because we wanted to geo-reference all the cases. And we've made these available on a website, which is called drugresistance.maps.org. Essentially, it just maps all the sites of studies where these genes have been looked at. And you can look at the year in which it was carried out, the number of isolates tested, and the number which were positive. And that is essentially what we mean by prevalence. We've also made this data available to an organisation called WARN, and they also have a website where they've mixed, or they've combined this with reports of the same, the prevalence of the same mutations in South America and Southeast Asia. So we've got global maps on the WARN website, which I'll give you at the end. So if we just concentrate on the 540, there are actually 260 surveys of looking at the 540 in Africa. I think you can see here where I've shown the where the prevalence exceeds 50%, shown in red. Where it was completely absent, it's shown by a blue dot. And where it was less than 50%, you've got a pie chart with a black colouring. There are still some countries where there were no studies. And what we wanted to do was to produce a map of recent prevalence, so we sort of honed in. These are all studies sort of listed by region and by year. We wanted to sort of capture what the current state of resistance was, so we looked at from 2004 onwards, which means that we're now reduced to 90 studies. Essentially, these describe what we know about the prevalence of this mutation in Africa in recent years. And you can see that there's largely this block of East African countries where the prevalence exceeds 50%. In many countries, it's approaching fixation. So our conclusion was that SP-IPTI is precluded in much of East Africa, but practical in the rest of Africa. So this lists the 8 countries where it was exceeded, and I would just note that Sudan and DRC were borderline, and there was very little recent data which could decide whether or not to roll out SP-IPTI there. But a question which we were all asking was whether these 90 surveys can really be considered representative of that whole geographical block, or whether we shouldn't be a bit more nuanced about where to roll out SP-IPTI. It's possible that the prevalence is varying a great deal within a country, although the map would sort of suggest that it does have this sort of gross geographical property, presumably due to its spread. So I'll just show you some data from a study we've been doing in southern Tanzania, in Lindi and Mtwara. Again, looking at cross-sectional surveys. Large numbers of people were looking at the parasite reservoir, so most of these people not actually sick, testing for the presence of the 540. During 2004, I don't know if you can read that, this is the presence of the double mutant, so it's the 540 with the 437. And the 50 or over is the dark purple. So you can see there is heterogeneity in the measures we made for these different districts within Mtwara and Lindi. But there's a sort of concerted increase in that prevalence over the subsequent 2 years, and you can see that that threshold was exceeded by 2006. And if we look at how it varies within the country itself, I'm going to now compare it with similar studies in the central areas of Rufiji and Kilombero and the northern sites in Korogwe and Magoda. Now, in the north, in Korogwe and Magoda, that's where the first reports of serious SP clinical failure first came from, and that was back during 1995. And you can see in red the northern sites, the sort of grey and blue central, and then the southern Mtwara and Lindi sites are in green, and the years are along the bottom. There's a huge amount of difference within Tanzania, reflecting probably the amount of time that these haplotypes have been present, and probably also reflecting the strength of selection. So different parts of the country are using drugs in different ways, so drug coverage is probably different in the north as well. It's interesting to note that it's also true for the triple mutant. We've got the same sort of geographical change as you go from the north down to the south. I've just included a study in Kilifi, just over the border in the north, which was carried out by Laura Certain, looking right back to the sort of 1980s when this triple mutant first emerged. You can see that's rising steadily. But the northern Tanzanian sites are sort of higher frequency. So finally, I'll just sort of say what the sort of Tanzanian study is showing is that there's a lot of heterogeneity even within a country. There's also sort of homogeneity in the type of alleles that are present. When we looked at lineages of DHPS haplotypes, so we're sort of defining these on the basis of the point mutations which are present and flanking markers which tell us if they have the same ancestral origin or a different one. There were 5 major lineages, 2 lineages of the highly resistant East African one, shown in blue and red, and 3 lineages of the West African mildly resistant single mutant, shown in yellow, green, and purple. And the degree of the trees sort of showing allele sharing, so they sort of cluster into these 5 major geographic regions, and they have in common in this whole region here. I haven't got a pointer, but that whole red region in Southeast Africa, it's the same alleles which are sort of moving around that area. So we're very interested in sort of following this up. We're looking at other markers. We're looking at patterns of migration, trying to relate that to the extent of allele sharing in these larger geographic regions of Africa. Here I'm showing a study by Andy Tatum and Smith looking at the degree of connectedness between countries in terms of migration and malaria, in terms of the extent to which people are infected with malaria and to the degree to which migrants will be exchanged between countries. And again, you can see there are these patterns of migration which broadly correspond to our sort of degree of DHPS lineage allele sharing. So it'd be very interesting to sort of go into this in a lot more detail. We're now pursuing it, looking at lineages of other resistance markers and also looking at markers which are not related to drug resistance at all, in order to try and get a better understanding of population structure over the whole continent. So my conclusions, firstly, that the collation of surveillance data is a prerequisite for understanding the global dynamics of resistance in malaria. And WARN is an organisation which has been set up to collate and standardise surveillance data, and this will form a vital role in coordinating and generating these big pictures of what's going on in the sort of dynamics of emergence and spread of drug resistance. My second conclusion is that molecular markers are really simple, so it's not simply a case of resistant or sensitive segregating in a population. But there are many partial resistance adaptations, and that can complicate the use of markers as a proxy for efficacy. So we have to be aware of that in these decisions about thresholds and changes to policy. And we sort of needed to know which haplotypes were present and sort of put all that together into the big picture before we could decide on a threshold of 50% of the 540. I think more than ever in an era of, so this is my final point, there's in an era of combination treatments where resistance to one drug, one of the partner drugs may be widespread, but it may not be visible in the clinic. It's going to be important for us to take a population-based approach in the design of surveillance systems. And that applies equally to sort of molecular surveillance and in vivo surveillance. And for that, we do need more information about population structure in Africa. So thank you. Finally, I'll acknowledge Imbarani's work in collating and mapping the reports of DHFR and DHPS, the IBTI Resistance Working Group who funded the production of our website, and the Gates Malaria Partnership who funded a lot of the work that I've talked about there. And finally also just to list all the people who are involved in the sort of mapping study in Africa. Thank you very much.